Dr. Richardson. This is Barbara Wash from the Department of Medicaid Services. It is 1 p.m. and I'm still clearing the waiting room.
Okay. Thank you so much.
Mhm. Currently, I just have you from the committee. Don't see anyone else here.
Okay. I know we're expecting two members, but we could go ahead and get started. And I hear an echo. Do you hear an echo?
Just a little bit.
Okay. Okay, I think it's gone.
Okay.
Great. Well, I hear an echo again. Let's see. Um, okay, maybe it's gone again. There's nothing worse than an echo on a Zoom, and I'm hearing it again. Okay. So I will not talk very much and I'll lead the agenda. So we'll go ahead and get started as people join. So welcome and thanks everyone for coming to our January Diversity and Equity TAC meeting. And we will kick it off if Leslie, Deputy Commissioner, is on to welcome or someone in her place.
I am still, yeah, checking.
I don't see her on here, but I'm Angie Parker. I'm the Director of Quality and Population Health. So I will fill in for her. And we welcome you, Dr. Richardson, and other committee members. And we look forward to discussing what we know.
Great. Thank you, Angie. And again, my name is Julia Richardson. I'm a pediatrician in Louisville at Family Health Centers, and I'm the facilitator. We don't have a chair. We've all kind of rotated through that, and now we're waiting for some of our new members. But we'll talk about that in a minute. We do not have enough members to establish quorum or to approve the minutes from October, but I've reviewed those. And then first thing in old business is an update for our new members. When will we get them?
Hi, Dr. Richardson. This is Erin. I almost called you Dr. Julia. I guess that works too. So we are still waiting on those pending at the governor's office. I have sent some information. I have been in touch with um, their lead who helps facilitate those. I know they've been hanging out there a long time. It's not from a lack of following up. Um, I am hopeful. We had a couple that were submitted for a different TAC around the similar time that are starting to trickle through. So fingers crossed. We know they're very busy over there. So I've been trying to work with their coordinator, as much as I can. Um, and I have reached out per your last email about some members who have not currently been showing and the best way to approach some of those. So I hope to have some information for you about that soon.
Great. And then Dr. Bautista and I roll off after the July meeting. Our second terms will be up. And so just be one.
Yes, and actually, I was going to reach out to Barbara, with this going on, if you guys are still interested in serving, I would almost suggest let's get those applications in before, as soon as we could get those in, just so that way maybe we can get them all approved and rolled out at the same time. So I know that we started reaching out about 2 to 3 months prior to other terms expiring, and it's just been a work in progress.
All right. Well, thank you for those updates. So just more
I wish
information
I
to
had better
come.
news. I'm sorry.
I know things are slow. Great. So the next is just a reminder of why we exist. And um, our goals are to bring a steady voice of equity to Medicaid. All of the tax address diversity and equity in some way, shape, or form. But our purpose is to solely focus on that. And we do that strategies are to have conversations and bring up issues and just keep things on people's radars and try to go as deep as we can to find solutions. We'll move right into our transportation access updates. Was one of our very first topics that the very first TAC we had a few years ago. And we've spent time the last two meetings trying to better understand what the issues are and advise Medicaid on that. And so I've asked Holly Hudnall to come back. She was at our two meetings ago, I think, to give us some updates from her work around transportation. And then we'll go into some follow-ups from the prior meeting. So, Holly, would you like to introduce yourself and give us some news?
Sure. I'm Holly Hudnall, and I am the Director of Community Engagement and Education at Kentucky Voices for Health. Kentucky Voices for Health is a statewide advocacy organization. We really work to represent the voices of consumers in the policies that directly impact them. So, a lot of work with Medicaid. Really working to elevate and protect that program because of the way that it supports Kentuckians, but also to make sure that that program is responsive to the needs of Kentuckians. So for the last 3 years, Kentucky Voices for Health has done a series of listening sessions every year in different communities across Kentucky. And we usually frame those discussions around Medicaid, how Medicaid is working. We've talked with folks about renewal processes, particularly during the unwinding. We talked with folks again this year about how Medicaid is working for them, as well as the impact that they felt that changes in the Medicaid program would bring to their lives. We talked to them about non-emergency medical transportation for each one of the last 3 years. We've also talked to them about oral health access. And this year we talked with them about school-based services. We had a virtual session that worked particularly with high school students through the student voice team. And those guys were actually very well informed about all of the topics, but were particularly forthcoming on issues around youth mental health. So Dr. Richardson invited me today to talk to you guys about NEMT. I was very glad to be with you previously to talk about some of the issues that we hear folks in communities talking about with NEMT. And I want to be clear that, our findings from the listening sessions are not a critique of the existence of NEMT. Everybody that we talk to in communities recognizes the importance of this benefit and how it supports folks in getting to health care when they have coverage. And we know that transportation is a really important part of that. When people don't have a ride to the doctor or to whatever service they need, they're not going to get there. That delays care. That ends up with more expensive care down the line as conditions deteriorate. So really, we want to make sure that folks understand that we are extremely supportive of NEMT. We want to see that it work well in communities. And so what the listening sessions offer is not a critique of administrative data. There's a lot of issues around NEMT that come up in communities that aren't captured by administrative data. And so what we're trying to do is to kind of surface those so that we can better understand the impact in communities. What we've heard pretty consistently is that there are some concerns around using NEMT, and it usually deals with the implementation. So things like scheduling challenges. NEMT has very strict scheduling rules that have to be followed, and they have limited hours. Folks have discussed, difficulty reaching brokers. There's a certain lack of flexibility in timing. Those can sometimes lead to pretty long or unpredictable wait times. For example, we had a provider that shared with us that she had a patient that had to get up at 3 a.m. to be on her NEMT shuttle by 5 a.m., to be at the office for an appointment at 12:45, and then had to wait for a couple of hours after her appointment before she was picked up and returned home. And those kinds of very long wait times, particularly when patients have chronic conditions or, a brittle diabetic, someone who is going for pain management, those kinds of wait times can be particularly difficult on those folks. Um, the when folks talk to us, they report inconsistent experiences across the whole of the state, kind of based on region or provider. The NEMT program is broken up by 16 different regions across the state. I think we have 12 different brokers for those 16 regions. And so there are we hear inconsistent experiences across those different brokers. And there is also a lot of confusion about rules and expectations when it comes to NEMT. I know that regulations changed last year, and those regulations haven't always been clearly communicated to folks. What we often find is that if folks have tried to use NEMT at some point in the past and they failed to be eligible for that service or to receive that benefit, they just don't try again. So, for example, the regulation around having a vehicle in the household versus having a vehicle in the person's name changed. But if someone tried to get NEMT services and they were denied because there was a vehicle in their household, they did not try again after the regulation changed and they would become eligible. And so folks really kind of have the attitude, well, I tried that once, it didn't work. I'm not going to try it again. And those are the types of experiences that are very difficult to capture in administrative data. When they receive a cert, they may not receive a survey. The survey is not great at deterrence, I guess, where folks have tried, they failed, they haven't tried again. That kind of information isn't always surfaced in survey data. The reason that this is important is because when it doesn't work smoothly, the folks that are most affected by this are the folks that have the fewest alternatives. So, particularly in very rural areas, people who have disabilities, particularly folks that may have intellectual, developmental, or cognitive disabilities, it's a tough system for them to navigate. And they're normally trying to have someone else navigate that system for them. But if there's any breakdown, if a driver is going to run late or a driver doesn't come back to pick them up, those folks with those disabilities aren't always the best to address that with the driver, the broker, the dispatcher, whomever. Um, and a lot of people may have negative experiences with NEMT, but those will often go unreported. And that is largely due, from what folks tell us, to a fear of retribution. If I complain about this driver, this is very possibly the driver that I'm going to have to rely on next time. And so when those systems, when they fear losing that future access or they don't feel confident navigating a complaint process, they just don't report. And I want to be clear that in the listening sessions, when folks do report negative experiences to us, we do ask them to go through the formal complaint process, but we don't require that they do that, and we don't collect information in order to do that for them. And that really is their decision as to whether or not they do report. And oftentimes they won't because they fear some kind of retribution or fear becoming labeled as difficult in the system, which they feel like is only going to make it harder for them. So what we found at the system level is that we have missed or delayed care due to scheduling failures. We have safety and accessibility and other types of issues that really aren't consistently captured through the complaint process as it is currently. We have a lot of disengagement where folks have tried to use it before, it didn't work, they're not going to try to use it again, or they've been discouraged by some of these other issues, and so they just decide that they're not going to use it again. And then we have some geographic inequities that kind of come from this fragmentation across regions and providers. So it's not any one broker, it's not any one agency. It's really more about where the choices around implementation kind of shape these outcomes. And that's particularly hard on equity sensitive populations. Um, so the takeaway is that NEMT is still really, really important. We want to highlight opportunities to strengthen that program, and not undermine that program. We want to continue to be supportive with DMS and DOT to make sure that the program continues to meet equity, access, and goals. So I'm happy to answer questions that you guys may have about the program or about what we heard in our listening sessions, if you have them.
Thank you, Holly. That was a great summary of, the reason why we have this on the agenda, and really looking at opportunities to help transportation and help DMS to identify and overcome barriers. So thank you for that. Any questions for Holly um, before we, or any comments? And so what internally with at KVH are you all, what are your current action steps to help move this issue forward?
Well, we've incorporated the data from the listening sessions. As you know, typically the listening sessions are a very important part of the way that we evaluate our policy advocacy, whether that's administrative policy advocacy or legislative, policy advocacy. We have made some recommendations through administrative advocacy, things like, having a more transparent process, doing more education around what the regulations are, not only for uh, brokers in their regions, but also just for the general public. We found a lot of times that folks don't even know that this is a benefit that exists for them. And so I really feel like personally that would go a long way to just educate folks about the benefit, number one, what they have to qualify for that benefit and what the benefit actually does. We hear folks that are not clear on that. They may understand that they can get a ride to the doctor's office, but don't understand that they may be able to get a ride to the pharmacy or get a ride to pick up their glasses or their dentures, right? If it's any Medicaid covered service, and folks just really don't have a clear understanding of what that means for them. So I think education would go a long way. I think standardized, our policy recommendations include that. They include, really kind of having a standardized intake process, so that everybody understands how to get qualified to get a ride and how to set that ride up. And I will be happy to provide you, Dr. Richardson, with a list of our policy priorities around or our policy recommendations around NEMT, if those would be helpful to you.
Thanks. When you brought up, very similar issues and your policy recommendations at a meeting prior, and we discussed them as well last time. I don't know if anybody from transportation is on today, Barbara.
I'm double checking to see, is anybody here from DMS? Um,
So we had a lot of follow-up
yeah,
questions from the last meeting that we were hoping to get some responses on, but
yes,
we will
I can
make
bring
sure
that
that,
back.
okay.
I can bring that back to DMS, and that would be on the agenda we could put it on for the next meeting.
Well, I do know that DMS and DOT did just recently do a survey, and I have seen some of that survey data, but I don't think I've seen all of the survey data that they had. So I would be interested in hearing more about that. So it would be great if we could have someone from DMS and DOT here, because I feel like if the committee has particularly technical questions about some of these things, they would absolutely be best poised to answer those.
Okay, I will make sure I bring that back and so we could have and to DMS for response.
Awesome, Barbara. Thanks.
You're welcome.
Barbara, it's
Yes,
Erin. May I suggest also reaching out to Jeremy Thompson with transportation to see if he might also be available for the next meeting?
He
yes, I
came
will.
last time, so that would be great to have him back. And then Justin, I think, and Derringer
Derringer,
too.
yes.
Yeah.
Yes. And Holly, you're right. I think the Department of Transportation does surveys,
Mhm.
and in the past, and they also, have a complaint line, but
Mhm.
nobody complains, just like you were saying. I'm sure there's a lot of good reasons why that is, but so when we bring our issues to them, uh, they they say, well, no one's complaining. We must be doing a good job.
Well, and
Um,
I feel like that's why the listening session data is helpful. I feel like there are various reasons why people choose not to pursue a formal complaint. Um, one thing that I've noticed is that that information is sometimes very difficult to find. It's not easily located on the website. The actual website, I think, is difficult to find because I'm not sure how intuitive it is for the Department of Transportation to have the Department of Human Services delivery. It's not an easy name to remember, and it's not an easy page to find. And so you kind of have to know what you're looking for in order to find it. So I think that may be one of the things that contributes to some of the just kind of general folks not understanding, is that sometimes that information is kind of hard for them to access. KVH has done a one-page explainer or tried to do a one-page explainer to kind of outline what people need to know in order to try to qualify for the benefit. And we were recently told that that needs to be updated. We had some information on there that was incorrect. But really trying to get as much educational material out that's correct and plain language so that folks understand the benefit and what they need to do, and understand that if they have a problem, there's a process for that. I think would be really helpful, Judy, to your point.
yep. Thank you.
Any other questions?
No, but we did get some of the transportation data that we had requested last year, and I think the request was have how have things changed over the years based on some of their internal policy changes and things like that. So I'm gonna share screen and just flip through that.
All right.
Awesome. That would be wonderful, Judy.
I'm going to stop sharing, Dr. Richardson, so you can share.
It said I had to request, so they're sending you a request. Okay, now we
There
should
you
be
go.
good. It was in the chat. Can you please share the one pager once it's available from KVH, the explainer?
Absolutely. I'll be happy to.
Okay. Okay. So there are three screens. Can you all see my
Yes,
screen?
we could see it, Dr. Richardson.
So there are three screens. This is 2022 to 23, then there's 23 to 24 and 24 to 25. And so it has every region. The region codes are listed there in the middle, the amount that was billed, and the totals. And so I think there was, let's see, let me ask you this. When were the policy changes around the assigned card to an address? When did that go into effect?
I would have to look up the exact date, Dr. Richardson, but I know that it was early last year that that really changed. Um, it-
So this it's some numbers. So the ICN count, which I'm not sure what the ICN means. I'm assuming that's per
This would be the number
person.
of claims, ICN count.
Okay. Okay. So I'm assuming that's, yeah, the number of claims. So you can see, I don't know the region codes off the top of my head. I don't know if Holly does. So I don't know which region applies to which, but I'll just show this today and then we can continue to bring it up next time when the transportation is here. And more comments. So this is the first one. You can see the total number is 80 million, right? $80 million. And then we go to the next year. And so this is 23 to 24. And so it essentially doubled. Um, I don't know what big change happened then, or if there was some billing changes or what that represents, because the next one pretty much the same, 100, well, a little bit of a drop, 55 million from June 2024 to May 2025. So it dropped a little bit um, in those two timeframes. So since, let me ask you this, Barbara, can I share this out if people want to see it, since this is an open meeting, even though we can't share the minutes?
I'm going to actually have Erin, can this be shared?
I'm
These
sorry.
data, the data for the EMT, is that able to be shared?
It's being shown in a public meeting, so it'll be on the website.
There we go.
Even
Yes.
though, well, but the minutes aren't because we can't approve them. So we'll,
Well, you're currently screen sharing so if it's shared in the meeting for open records, um, open meeting laws. I don't know why I said open records. My
okay,
brain is at home today. So it will be posted on the website as your NEMT data request. And so anyone should be able to access that.
perfect. Okay, so
Yes.
those are, thank you so much for
You're
clarifying.
welcome.
So those are the three, so people can dig into that and look, and I'll bring it up again next meeting when transportation's here. So um, I will stop sharing now because you all can access that.
And one question you might ask them, Dr. Richardson, is if they have any sense of the breakout. So one of the places that we understand that NEMT works extremely well is with adults who use, for instance, adult day services. It's a regularly scheduled ride. It tends to come at the same time every day. And that tends to work really, really well for those folks. So I've always wanted to see if that is a number that they could break out of those totals, to kind of break down like who is using the service and for what types of rides. And another question that might be interesting there is, um, you know, NEMT is set up to pay based on how many folks in that region have Medicaid. Um, and so, whether my understanding is that whether the broker provides a ride or not, they are still paid per member in that district. And so I would be interested in kind of understanding what that relationship is in how they break down the cost comparisons. And that might be interesting information for the TAC to look at as well.
So the regions are or the brokers are paid per member,
Yes,
not per service provided.
no, that is my understanding. They are paid per member in the region. So, whether, that I think that has an effect on the structure as well. Um, so I'm just curious when we're seeing those numbers and those dollar amounts, is that the dollar amount per person in that region, or is that the dollar amount that was actually spent to provide rides in that region?
Yes, good question. Thank you. Okay, so lots of qualitative information, right? We've got the listening, we've got our shared experiences with the members we're working with, and then we have the lack of the complaint process because it's fraught with many issues, least of which is retaliation issues when, especially in smaller towns, when there's one or two drivers and people will know. So that makes the qualitative data even more data, the qualitative information even more important that we find a way to really effectively listen to that. So thank you, Holly.
Thank you for having me.
Um, Dr. Batista had a question.
And particularly, thank you for the information, Holly, because you are saying that is the amount of money per member. So it would be interesting to know the percentage of the members that are using the service, and if not, who is using this money, or what is happening to this budgeted money that is already there. So it would
Right.
be. Mhm.
And I want to be clear that the amount of money per member is very small. So I guess my question is like, if they are paid per member in the region, like what is the breakdown? Like, how does that work? How is that working, right? Because what I think that my general sense is that it's a smaller number of people that need a greater amount of rides. For instance, that adult day population, right? These are folks that typically don't have driver's licenses. They have some type of disability, and they receive a ride 5 days a week to and from daycare, right? So you can see how that particular member would obviously have more expense, right? So I'm just interested in, what are we looking at if they're paid per member in the region? What are we looking at there? How does that break down per ride, I guess?
And I think that's particularly important for us because when we were asking questions and not asking for more services, but more resources like, well, let's do the standardized intake. Well, that's resources, right? And let's make sure that language access is prioritized. Well, that takes resources. And it's really important to understand all the dollars flowing in car seats. We brought up a lot of things last time that the response was, well, the brokers have to pay for that. And it's important that we know, do they have enough money? Or is it a really tight budget? Is it a budget that could possibly ask for some of these um, things that we really feel are important from an equity perspective? So
And absolutely. And there have been suggestions that are really low cost. For example, we had one of the community health workers who works particularly with immigrant populations there in Louisville. And she was like, can they just leave a card when they've been there? One of the issues that they had was drivers saying they had been there. The member says, I was waiting and they never showed up. She was like, can they have just a card that they leave to say, hey, I was here and I missed you? Or like, that to me that would be just that's a fairly low lift, right? Or how's my driving sticker, which my understanding is that information is supposed to be posted in the vehicle somewhere. But a how's my driving sticker, which is another relatively low hanging fruit that could be picked for a minimal amount of money. So I think that yes, there are solutions that would be more expensive, but there are other solutions that may be far less expensive. So, and I think that those are, obviously we all have budgets at home. We understand that compromise is necessary, right? Especially right now.
yeah.
So, Dr. Richardson, there is a post in the chat from Leanne Fitzpatrick that said per member per month.
Yes, that's how brokers are typically paid.
Mhm.
The per member per month.
Yes.
What other comments or questions or things that we want to get on a list to make sure that we ask transportation next time or DMS? Okay. You are welcome to stay on if you would like, but thank you. And we would love for you to come next time as well if you're available. Oh, another question. Can companies track their drivers?
My understanding is yes. That would be a question that would probably be best posed to DOT or DMS, but my anecdotal understanding is that yes, almost all of the brokers have GPS tracking devices in the cars at this point, so that they can track their drivers.
Other questions? Do they submit those reports to, you mean transportation or uh, is it Tiffany or Hallie or Hal Tiff? Submit the reports to who?
We have never asked, like we at KVH we have never asked for those reports, so I have absolutely no information to share with you about that one. That's a question that would probably need to go to DMS or DOT as to whether or not those reports are submitted to them.
Okay,
Yes.
thank you. Appreciate that.
Okay. All right. Well, any improvements or have a huge impact. So thank you all. Thank you, Holly, for all the work that you're doing with KVH to keep this moving.
Thank you. Thanks for having me.
Hey, I think we could pull the agenda back up if you want to, Barbara. The next item on the agenda is just I left the community health worker spa update on there. The members of the TAC received a copy of the spa after the last meeting. So thank you, Aaron, for that, or Barbara, whoever sent it, I can't remember. But those of you that work with community health workers, I'd love to get some feedback on your thoughts on the spa. How is was it what you all wanted and expected? Any challenges so far since implementation? If there's anyone that does a lot of work with community health workers. And so I'm going to leave this on the agenda probably one more meeting. So if you know any community health workers that are within your agencies or that are your community partners, if you would just send them a quick email, ask them if they have any feedback on the spa, if they're aware of the spa. The spa is, Aaron, I think it's publicly available, right?
Yes, ma'am. Well, let
Um,
me verify because every 3 years they come off and go back on to keep our website clean. And off the top of my head, I don't remember what year that was approved. But if anybody ever needs a copy, all that is actually in the state plan website pages that are on the same website page. And they're always welcome to reach out to myself and Barbara to help point in the right direction. I can drop that link in the chat. Give me just a second.
yeah, that'd be great. I mean, it looks great to me, but I'm not a community health worker, so I would miss a lot of the nuances there. So we'll leave it on one more agenda.
Okay.
We will just touch base on the interpreter Medicaid access, the flyer, the update on distribution. So at our last meeting, we discussed or last or the prior that if you have fee-for-service Medicaid, interpretive services are not an option, but with the MCOs, they are. And there was a one-page flyer that had been developed maybe 2 years ago. And I'm assuming DMS created that since it has all the MCOs on it. And we had talked about how do we get that out, especially to providers and members, so that everyone is using that. It's distribution is hard. I know that even just within Louisville, information does not get out, and people are not aware of opportunities like using the MCO provided interpreters. Okay, so we have a couple of things in the chat. The NEMT explainer, and then what is the Rachel, the interpreter?
Yeah, I think Leanna was going to speak on it right at that same time, so I'll go ahead and turn it over to her.
Okay, thanks.
Hi, yes, Leanna Trainer with the Division of Quality and Population Health. We did publish the interpreter flyer back in November. That is also on our website, both in English and Spanish. We've also published on our social media pages, trying to get the word out, and also shared with the MCOs. We can provide to the TAC if that wasn't sent out. We believe a copy was sent out right along with publishing, but I'd be happy to send that to you as well.
Great, yes. If you'll send that out. So if we could hear from just any of the MCOs, how you're distributing that to members or providers at like actively distributing it, if anybody has any comments. Well, that would be a good goal for 2026 is just get this in everybody's hands. I'm going to print off the new one and just give it to every single patient I see. That's when they are going to the dentist and going to the pharmacy, and they need to, the places where interpretive services are less likely to occur, they need to have it in hand. So I'm just going to click on that real quick. Okay, I am on the website. Where is it on that link?
I just posted a screenshot. I had a feeling that was going to be the next question, so I tried to get ahead of it.
Thanks. On the far right.
Just scroll down a little bit there on the right under additional information. And we titled it Medicaid Language Access Guide.
Thank you. But yeah, I would just, I work.
This is Holly.
Go ahead, please.
I apologize, Dr. Richardson. This is Holly with Passport, and we have language interpretive services blurbs on all of our letters that we send to members. If they receive a denial for service in their new member welcome letters, there's a page that basically says, if you speak this language, then we can help you, and it's in multiple languages. So we do share the information far and wide that interpretive services are available, and we make our providers aware as well.
Great. I think a lot of people get confused between interpretive services available to communicate with Passport and interpretive services available to communicate with your pharmacist. And I think that sometimes people think that they can only get those interpretive services like when they're calling for Humana, versus they can use this phone number externally in their medical experiences or health experiences.
This is Dr. Figueroa, Wanda Figueroa. We also provide the information. However, I'm more interested in helping community members become certified interpreters. And there is it's such a cumbersome process to become an interpreter, because there are a lot of nuances, language nuances or cultural fits that are not uh, accommodated for or cannot be interpreted that could be useful for the healthcare provider. And so we want to develop that capacity, but we're having such a difficult time accessing. The test dates are far in between, so that might be something that I encourage that someone from the Commonwealth speak to that issue and how we can improve the pathway for certified interpreters.
Is there anyone from DMS that could offer some information on that?
I don't have, this is Leanna Trainer again. I don't have information directly, but knowing that we are targeting a lot of different SDOHs, including language and interpreter services. So I'll take this back with my team to see that we embed that in our projects for 2026 and see what kind of data we can get you regarding how those are breaking down.
And so would it be, Wanda, that you would like more training to be available at like a low cost, or what are you thinking?
Um, eh, eh, test dates and also information and timely responses for people who are making applications or are trying to find out where and when they can take the test and all of that.
And what agencies are you referring to get the testing done? Is that
For example, if someone wants to become certified as a Spanish certified interpreter, there were like two test dates available in any given year, and or they have to wait if they didn't pass the test the first time, that they have to wait quite a longer period, and so that's.
and who was doing the tests? Do you know?
I will get the link and send you the information because as we were discussing that, that came to mind. And I know we have some staff members that were interested in becoming certified interpreters and moving to that position because we would like to create that in order to provide services to the Spanish-speaking and Burmese population. And that's an ongoing issue.
Great. Yeah, if you want to
Yes, I will. I'm looking for it right now.
and Dr.
Yeah.
Batista.
Yes, I think in Louisville there are two agencies that would apply the interpretation certification tests. One of them is Catholic Charities, but you have to train with them in order to become a certified interpreter. And there's another one. I do not recall, but as soon as I recall or I get the information, I will share it with all of you. But I think these are two located in Louisville. I'm not sure about the west part of the state.
That's another, yeah.
Also, Dr. Richardson, I was able to open up the flyer, and the thing that says is if you need interpretation, they just provide them the phone numbers for each MCO.
Mm-hmm.
Mm.
Yes. You said you could not open it or you could open it?
Yeah, I did open it. It was a download, and it says you are, eligible to get interpretation, but you have to contact your MCO.
Yeah, each of the MCOs have their own, but if you're fee for service Medicaid, you don't have access. So a lot of the people that maybe, well, they're the people that are on fee for service. So that would still be an opportunity. Okay, so just keep testing and testing these numbers and giving feedback to the MCOs if there are problems, uh, and get the word out. We've talked about our experiences with these numbers and sometimes long holds. You have to push multiple buttons to get where you need to be, and then a hold at each button. I think I did one once, and it was about a 7-minute process to get to an interpreter. So I would encourage you all internally to, within your MCOs, just to try it out and give feedback internally because I think we all value how important it is, and we want to make sure that it's of the highest quality for our patient outcomes. The next thing is on demographic data, race and ethnicity reporting and equity. We talked about some opportunities at the last meeting. I forget to formally ask for those. I thought, oh, if we talk about it in the meeting, then that will happen. But I think we have to formally request that data. And so we talked about starting with some immunization data last time. So I'll submit a request on that based on our last conversation. But since the last meeting, are there any updates on opportunities around demographic data? Do you have richer data? Do you all have any suggestions on where, like, we might get the most information based on what data is available?
So I think Leanne or Angie may have that information.
Yes, this is Leanna Trainer again. So we have gone live with a few different reports that are going to be capturing a lot of information from the members' demographics and their SDOH needs. Those are directly from the screenings that are done through the Medicaid application. So we haven't gotten those reports in just yet, but we do expect them to start rolling in, and we'll be analyzing those and sharing during our next meeting out. With this specific request, we were unsure exactly which areas you were looking for. So if there's specific areas, I wrote the immunizations down. But if there's any other areas that you specifically want to look at that data for, we can look at that.
Great. I'll pull that out of the last meeting minutes and just send it to Barbara, and then she'll get it to you. Does that sound okay?
Sounds good.
And then Judy, I don't know, or Dr. Theriot, I don't know if you have any ideas or suggestions on what might be an effective ask that we can get good data on. Are you still on here?
I am.
Oh.
I'm not sure. I love the stuff that Holly was saying about NEMT. As far as interpreters or language services, I think that's really difficult to, it's not really data that we get. I know Rachel's on here. She might have a better idea of how to kind of get at that information.
Well, one
Or
thing that might be of interest to you, to speak on what Leanna was talking about with new reports with SDOH and kind of stratifying out. One thing that we're starting to get are all the critical needs that are being reported to us by our members. So transportation being one of them. And so they'll let us know in a variety of very specific scenarios, like they have a car, it's not running, or they use public transport. We can get very detailed, specific information there. And then that can be stratified by race, ethnicity, age, gender. And then also one of them is by spoken language. So it kind of ties everything in a little bit together there. So it's not exactly what you want, but that is something that that might kind of scratch that. It's just a little bit, and because that's something with these meetings that we have been working on is being able to get that fine-tuned information from our members. I hope that helps.
Yes, and so yeah, that would be great to get. Can I just ask you to give us some at the next meeting, or do I need to put that into a formal ask or?
If you'd put it into a formal ask, we'd be very happy to get that for you. No problem.
And then Judy, on the clinical data, any other clinical topics that you think would be that we would have enough demographic data on in general? Um, like we talked about immunizations, like some of the immunization categories last time. We'll submit that as a request. Anything else?
I'm trying to think. Of course, I go to, yeah, well child visits is a great thing. And I'm almost, I don't know how to get this, but, things in maternal health like C-sections based on race, ethnicity, MCO, that kind of stuff. But, yep,
Okay.
well child visits, immunizations. I'm really worried personally about immunizations with the recent changes that were made that that people are, going to just not get more shots. We're already seeing it, but we need to kind of follow that and see if there's patterns and see if it's, affecting our members that are more at risk than others. Um,
Anything around anybody's PIP? Like, is there a common PIP that we could ask? Pat, anything like that?
we have the oral health PIP, or maybe it was a focus study. Um, other things are big, adult type things. Christine put in there the tobacco cessation, and I think that's more adults. I think we have some adolescent information in there, but it's not much. But that's a good one too.
Great. Okay. I'll send it out to the committee, a list, and if anybody wants to add anything or take anything off, um, thank you. Okay, the next thing on the agenda, I know sometimes DMS staff cover more than one topic, so jump in however you want to cover these next couple of topics, but um, racial equity core team updates.
Yeah, this is Leanna Trainer again. I'll take the next few. So the Racial Equity Core Team continues to meet. However, it is an internal team with the divisions to just kind of share racial equity tools and report out on division activities. I'm not sure if there's value on reporting what those activities are directly to the TAC. So we were recommending that this be removed as a standing agenda item, or if not, if you can provide some clarity on exactly what you're expecting or wanting to see from them.
For that one, we would love maybe to do another overview to see what you all are talking about, and then we could pull out um, if there is anything we want on a regular basis. So do you want to give us an overview now, or do an overview next time? So then we would know what might be helpful for the tech to advise on.
Yeah, sure. So a high-level overview is each division is represented. We meet once a month. We do have a commissioner's corner where we have Dr. Terrio provide either a presentation or a video to kind of drive some discussions. The Division of Quality and Population Health also provides some videos as well. And then we'll have, it rotates. So we'll have one division that provides a presentation, and that's usually on any projects in their area that touch on equity or any upcoming events, any data that they may be able to share that's relevant to, again, racial equity, demographics, things of that nature. And then we close out with any document requirements that we may have, as well as sharing any new equity tools that have been released.
Is there, I think last time we talked about, as far as education for the members and the attendees, I'm sure what Dr. Terrio presents is amazing, and that whatever the individual divisions are presenting is really good education for this group. Where could you see kind of pulling out some of the content, sharing a video, or going through some of the content just to help educate us as well?
Yeah, sure. If you like, what we can do is a running list of, since the last time we met, this is the videos that we've shared. We can provide a link. We can also provide a copy of the presentations, assuming that our communications staff will approve that for public distribution. There's a few different ideas that we can do with just providing those educational resources, as you say, to a broader audience.
Maybe some pizza.
Sounds good. Okay, thank you. Did you say you were going to take another one as well?
I'm sorry.
Did you say you're going to take another one of the topics as well, or?
Yes, moving us on to the Division of Quality, mix, sorry, jumping guns. So the Medicaid Innovation Collaborative has ended. There's no new updates on that. Right now, there's some expanded projects that are going on with the MCOs in Good Samaritan. But aside from that, there's no new updates, and we do recommend to just remove this from the agenda. If those projects get steam with the MCOs, we'll have either them or ourselves report that out at that time.
Is there any closing sort of report that we could cover now or at the next meeting, just to kind of wrap it up and remind everybody about the work?
Yeah, absolutely. We'll look to doing that for our next meeting.
Okay. Great. Okay.
And then moving us on to the Division of Quality and Population Health, we do have a few different updates. Like we said, we did finish the interpreter access form that is live on our website. We also do have a few other documents that we published during this time frame. We have a disaster relief guide. We have a maternal health resource guide. And then we have the MCO 2026 Value Added Benefits, a side-by-side comparison. For all of those documents, they're accessible in both English and Spanish. And naturally, we are prepared to translate those if we get any requests for additional languages. So that is out on our website under the member information, the same link that Rachel had dropped earlier.
So you said interpreter access form, the mental health resources, value-added benefits, and what was the fourth thing?
Disaster relief.
Disaster. And then from the tax perspective, we can advise. And so any feedback, or what's your process for feedback on these forms? Kind of when you develop them, how do you incorporate sort of a equity perspective?
Yep. So for our division, quality and population health, we have a standard operating procedure that embeds the GARE tool along with some questions that are specifically geared to make sure that we have all the stakeholders that should be available, as well as any feedback from the teams, both internal, external. So we use that for any of our projects going forward and since March or April of last year. And then as far as a regular review, we plan an annual review of all of our documents to see if there's any updates that need to be made and to get those published accordingly.
Great. Any questions on that for Leanna?
Right. Then another update from the division, we have population health that has started to attend MCO held community events. So our goal here is to get a better understanding of what the members are reporting when they go to these events, how successful they may be, collaborating with the MCOs to see if there's anything that Medicaid can do from our perspective to help with the success or outreach of those events, and to really gain from a member's perspective how those go, and what we can do from a policy perspective to change either those benefits or services in general.
So that would be a good advisory question to us as the TAC, sort of what you're trying to achieve at those community events, sort of some of those same questions to Wanda and Dr. Batista, and or let's go by first names, Wanda and Patricia and I. So what would be some sort of goals attending the community meetings and getting direct feedback? And could you ask some of those similar questions to us?
Yeah, sure. So we are pending a report approval that'll have some data elements that we plan to track on a regular basis. The number of attendees would be one, as well as the expected attendees, how many reserved versus how many actually showed up, if there were any supplies that were released, how many kits or supplies were given out, or any referrals that may have been taken in response to the event. And then also looking to see if the MCOs are addressing any kind of barriers to attending those events. So we want to make sure that members with either transportation issues or language issues, interpreter issues, have those embedded in the events to make sure that we're trying to get as many people to attend as possible.
I know the three of us always think about the families that we serve, and pretty sure none of the families I work with ever go to an MCO event. And I don't know, Patricia's nodding her head too. So there's just so many opportunities to reach out and find people and being creative on how members are reached.
I may add that some families that come to our community organization may go to MCOs to organize events, particularly if they are geared towards the language that the community that I work with is, using. So we have events with Humana and also with Passport. They hold those and then they invite us, and family members of community members will go.
Direct partnership. Yeah. Wanda, what about in your community, the community events by the MCOs? Any thoughts or feedback with the clients you're working with?
I think some of the MCOs are more effective in their outreach to the community. It depends on membership, but in some cases, especially if you're in Medicaid, you may be assigned to an MCO. So the feedback that I'm getting, like from case managers that participate in this meeting and encourage family members, especially new patients, to participate in this forum so they could get more information about the services or changing in their offerings. Has been helpful. But I think that we have to do more of that, and to continue expanding opportunities for the community to know not just the healthcare services that are available, but all the other support services that address their social determinants of health.
Thanks for sharing that. Um, just moving on, any other comments for Leanna? And then the next thing on the agenda is the equity and determinants of health branch manager updates. Is there a branch manager of that, or am I remembering that got changed internally, or?
Yes, Leanna Trainer again. That has been changed. Population Health will be taking over equity related activities for the division and helping to oversee equity activities for the department. And we will not be pursuing that position.
Okay, thank you. So I'll take that off the agenda. All right, the next one, I'll share screen again. We got a report on, I believe that's what the report is received. Let me pull it up. Just 1 second. Oh, before we move on, there was one other report, the lead data we had requested. Let me pull that up under our equity discussion. Okay. Let me share. Okay. Can you all see that screen?
We could see that screen, Dr.
Okay.
Richardson.
So we had asked for some data around lead testing in the different areas of the state. And so just to try to get a feel to see if there was anything within data that could give us some insight into lead issues. So looks like there were, and we'll ask for potentially somebody from public health to come and go through this next time just to make sure we're understanding it. But
Dr. Richardson, this is
yes.
Erin. Sorry, I wanted to step in. So there was, and part of the reason this one took a little longer is the request was for Medicaid data. So we had to send it through our Medicaid data. So this
Okay.
is not the public health report. From my understanding, that is different. And because the tax request said Medicaid claims, um, there was some back and forth on whether or not that could be provided and how it would accommodate. So my suggestion is we could maybe make the ask of someone from public health who does lead testing if they could come and talk about their process. Because this is just from a Medicaid data claims point. So they may actually have more detailed information.
But just for the data to understand the actual numbers, Medicaid can help us understand actual numbers, right? So the first number, is that the total of Medicaid beneficiary total, or is that eligible, or that 14? No, 1.4 million.
Sorry,
There's no comma, so I have to look 1, 2, 3. So 1.4 million listed as a total number. So is that total number of Kentucky Medicaid beneficiaries?
That's what it says.
If you can give me just a second, I'll pull it up.
Sure.
I'm having a hard time seeing it.
Okay.
God did not give me good vision.
I'm having trouble seeing it too. I'm sorry. Oh,
If I know how to, I'm not fancy enough to know how to.
but I know we have like 1.4 million people. So,
Okay, so that would be
and
that.
Funds.
so that would be that. And it makes sense to me. I mean, just about the 2-year-olds, because we get about 26,000 births a year
Okay,
on Medicaid. So, that makes sense that we might have that many 2-year-olds.
perfect. Okay.
Um,
And then the next is the number of the total number of tests by 27 months. I'm assuming that's what that number is.
I'm not sure. It looks really small.
And then the next is the total number of pregnant women. And then the number of screenings of people who were pregnant. That number is
Yeah,
really, really small. But it could be true
really, really
because
small.
there's not a lot of uptake on pregnancy screening, which we have found two crazy high ones in Louisville and lots
Ooh,
of a little bit of high ones. So it is something that needs to happen. Okay, so I'm just going to run through the data. Okay, so the next one is broken down. Okay, see if I can figure this out. So by region, by, okay. Okay, so the first is zip codes, and it's a count per zip code of, I'm not sure what this is. So this is total number of 2-year-olds by zip code, by race, by gender, and by region. Okay, so this is just the 2-year-olds and where they are. The next one is the lead tests. So I'm assuming it looks like these are the people who were tested and had two. So the standard is at least two lead screenings, lead blood test, one at age 1 and one at age 2. So that would be the standard of care. And then broken down by zip code, race, age, gender, region. And again, this will be on the website. I'm just kind of presenting it, but it will be there to look at. We can continue to talk about it. This next is the pregnant beneficiaries by zip code, race, age, gender, and region. And then the women who have been screened with the same categories.
Dr. Richardson, I'm sorry I could not get my Excel sheet to pull up because my entire computer froze, but I was able to get the Word document from the original data request pulled up. Gotta love technology. So the TAC did ask for paid claim data for lead screening for codes, mapping to HEDIS measures, number of members who turned 2 in 2024, number of members who had paid claims, at least two lead level screen/tests, um, above or equal to 27 months of age, number of members who were pregnant in 2024, number of pregnant members who had paid claims, at least one blood lead screening. Does that help some?
Yes, yeah, and those are the tabs are at the bottom. And so again, this will be on the tech website so people can blow it up and or zoom it in and look more carefully. And looking at the differences in from an equity perspective. So if we just look at this last screen is pregnant women who have been screened. And if you just look at the race data, so 149 Black women, 114 white women, 81 Hispanic women. You can see most of the testing has been, I think that's because we're doing a project with the March of Dimes to start lead testing when it's not typically done. Although it's nice that in the mountain region and in Bowling Green, they've done a fair number, but only 11 in the Blue, which will tell you that it's just not commonly adopted practice to lead test.
one thing
So this would be
that
great data to support testing.
it would. One thing that I'm concerned about or I'm thinking of is the WIC data, because usually WIC has their own kind of pot of money and they screen for lead and they also screen the pregnant moms. And so I wonder, and I also understand that WIC is underutilized, but I wonder if this is an underestimate because people are getting it done in the WIC office. And
So WIC in Louisville stopped lead testing several years ago. It may have been during COVID that they stopped. I can't remember. And they're not testing pregnant women for lead in
okay.
WIC.
Oh,
Maybe
well,
they
good
used
for
to.
them.
Yes.
I
Well,
know we
my
used
thought
to in our
was,
clinic, but
yeah, yeah. And I'm talking about health department. Could be that Novak is still doing it. I don't know. Uh,
yeah.
the thought I had was the in-office testing. You know, some people do in-office lead. I don't know how that's billed out and if that's captured by Medicaid either.
It is reimbursed, so if they code for it, it will be a claim.
Um, but with dealing with the data we have, knowing that it has some limitations. So if we just go, let's go back to the 2 visits, um, uh, 2 lead testing by the age of 27 months. Um, there's a broader distribution if you look at the regions. So people are testing for sure. And if you look at the race data and the other categories. Okay, so yeah, so please feel free to dig in. So comparing in your region the number of 2-year-olds versus the number of 2-year-olds tested, and yeah, so this will be posted to dig into, and we can have follow-up discussion on that. I'm gonna stop share and then pull up the next data document. But any questions about the lead or comments? Let's see, there's some content here. Christine said, is that for those who are identified by high risk? So is this for the lead? I think that's the lead question. So all Medicaid kids are supposed to have a lead at age 1 and 2. Um, ACOG is not as definitive on their recommendations on lead testing. So probably why most women don't get tested for lead, even though their child is getting tested for lead, because they are deemed high risk. So, and we're finding it's just it needs to be done based on our data and pilot that we're doing with Metro United or with the March of Dimes.
Dr. Richardson, Erin just suggested she had to get off the meeting for another meeting. She suggested we have someone from public health come out the next time, maybe to go over this.
Well, I mean, I will welcome them to come, but I think the I don't know that they would have any comments specifically on the Medicaid data. Do you think? Because I think that's what we're trying to drill down on. Do they have? But they have testing data as well.
I'm not sure. I would have to bring that back and ask that to come back. I could always ask, make an ask. So,
Dr. Richardson, I think it would be interesting to see if they are doing the testing to compare the data that you just shared with what they have. The one that you have is specific to Medicaid, beneficiaries. So that would be a good comparison.
I think public health only gets elevated though. I don't think every number is not required to be reported. Only elevated numbers are required to be reported.
okay.
To public health. But
So
they are welcome
I
to
will,
come.
yeah, I will make an ask for that and come back with an answer and send it all out to you all.
Okay, and then the last data point I have. Stop share, or did I stop share? Okay, let me go in and get this last. So this, I believe, is the CHFS. I'm not sure, but I think that's what it is. So you can tell me. So the question has been over time in the CHFS listens data. That's the like the ombudsman, I guess, lack of a better word. What equity issues come up during those phone calls that when people call to ask CHFS listen. So is that correct, Barbara? Is that what this data is?
Yes. Yes, it is, Dr. Richardson.
So you can see it's in big categories. But on the second page, and this will also be posted to the website, you can see once it hits the waiver calls. So there are a fair number of questions around waivers. And I would really be interested in that. I don't know how much more detail we could get. There was only one transportation call. So I guess the question would be, can we get more drill down on the waiver questions, or at least the big categories?
I could bring that back to DMS.
Okay. I'll go back up to the top, just kind of let people scan. So we've got 87 for billing inquiries. There's 20 around MCO inquiries, managed care, the kind of generic term. Eligibility, there was 58. 86 just says member services inquiry. So seems like a big category to not have much detail in. 46 other. And then there's a 65 under phone other query. 94 under services inquiry. So that there's some significant numbers in there. It's kind of hard to tease out. So maybe we'll start with questions around the waivers, and if they can get us more information, then we can go back and see if there's any other equity opportunities to learn about some of the categories. Other comments or questions on this data report? All right. Okay. The next two topics, new business, general discussion. Anything new that we want to bring up or new topics or and then we can't make any formal recommendations to the MAC. We can make comments. I don't know if Wanda or Patricia, if either of you all are available to attend the MAC and listen and make comments. If you all would, between the two of you all decide with the next date if either of you can go.
I attended the last one and it was just sobering the impact of all the changes on budgeting that is already happening and that is going to get worse, and the huge disparity between urban and rural, and the deserts for healthcare attention all over the Commonwealth, but mostly for maternal health, and how the maternal mortality has little by little increased since 2020. And so I may try, but I'm not sure. It's a long it's a long meeting. I may try that one. She jumped out of the meeting, but I may try it again just to get a sense of what is important. If we have anything from the TAC for me to share, I may try to take it to the meeting.
Thank you. Thank you. Yeah, I think just acknowledging that we do exist as a TAC probably is good since we typically can't, we haven't met quorum to be able to give anything at all. So just being there if you can is great. And Judy, I don't know if you have any comments on the maternal health increase in health
Well,
issues.
we were awarded the base was 200 million and we were awarded almost 213 million. So more than other states, not the best. The people with the biggest landmass like Alaska, Texas, California got the most, which makes sense. Um, but this initiative, the Rural Health Initiative, is being headed up by Public Health and Dr. Langfeld, who is now the Commissioner of Public Health. And he is working very diligently on getting things up and running because we're not promised the same amount of money. We put out a proposal. Now we have to deliver on that proposal. If we don't, or if they don't think we did good enough or whatever, they can just take the money back or just not give us any. Um, and so I have more to come probably at the next meeting, but maternal health is part of that rural health transformation. It's one of the 5 pillars, and the goal is to increase access to care and quality care for women living in rural areas of the state. So,
Well,
so
congratulations.
excited.
Huge. Yeah, it's very exciting. Great. Any other general discussion or new business? Okay. And then we have our next meetings listed there, April, July, and October. And don't forget to go to the website for the data that was presented. Oh, thanks, Leanne, for putting that in there. And then since we don't have a quorum, I guess we just adjourn, but any other business before we adjourn? Okay, well, thanks everyone for your time. We'll see you in April.
Thank you very much.
Thank you.